Imagine looking at a dry erase whiteboard in a hospital hallway, and scribbled in red marker is just a single number, 4.
Yeah, which is terrifying when you know what it means.
Right, because that 4 means that is exactly how many units of blood your entire hospital has left for the night. But, you have 10 patients bleeding out in the emergency bay. So how do you decide who gets it and who doesn't?
It's an impossible choice.
And what happens to your brain, to your fundamental sense of humanity when you have to make that choice every single night for 90 days straight?
Well, that scenario is the absolute crucible of disaster medicine. It forces us to ask what happens when the textbooks and standard operating procedures are just completely incinerated by the realities of resource starvation.
Exactly. And that is the exact reality we are exploring today. We are taking a deep dive into this really gripping real-time medical field report. It's titled The Modern Mosaic of War Trauma Surgery by Dr. Reza Lankarani.
Published in the Genesis Journal of Surgery and Medicine in June 2026.
Yes. And this document synthesizes data from the massive bombing casualties in Iran between March and May of 2026. And I want to say right up front to you listening, you might not be a trauma surgeon, you might never even set foot in an operating room, but this deep dive is a masterclass in extreme adaptability.
Oh, absolutely.
It's about resource management and how human systems endure or completely collapse under unimaginable pressure.
It truly is. I mean, this report gives us a completely unfiltered, granular look at that collision between modern medical doctrine and the chaotic, brutal reality of a prolonged mass casualty event.
Also, just to be completely clear before we begin, we're looking at this strictly through the lens of the medical data, the human endurance, and the logistical realities outlined in the source document. We are not taking any political sides regarding the conflict itself. Our focus is entirely on the medicine, the data, and the people holding the scalpel.
Right, the clinical reality.
Exactly. Okay, let's unpack this, because we have to start with the sheer, unimaginable scale of a single blast injury. I think we tend to think of trauma as one bad thing happening to one part of the body, but that's not what this is.
Not at all. Bombing trauma is, by its very definition, polytraumatic.
Meaning multiple systems at once.
Right. The blast wave, the shrapnel, the thermal energy, it all hits the body at the exact same time. When a single missile strike occurs, it creates casualties that routinely require 8 different surgical specialties simultaneously.
8?
Oh,
wow.
Yeah, 8.
So for anyone listening, just picture a single patient on a table. They need a general surgeon to stop internal bleeding in the abdomen. They need a vascular surgeon to save the main arteries in a mangled leg. An orthopedic surgeon to stabilize shattered femurs.
A neurosurgeon for the brain.
Right. Plus, maxillofacial surgeons for the jaw, plastic surgeons for tissue coverage, burn specialists, and urological or thoracic surgeons. All at once, for one person.
And, in a standard peacetime level 1 trauma center in London or New York, you might actually be able to page that exact team of highly specialized experts.
Right.
But the staggering statistic from this field report is that less than 20% of these definitive surgeries were performed by formally trained war trauma surgeons.
Wait, less than 20%? So who is doing the other 80% of these incredibly complex surgeries?
Generalists. Civilian general surgeons.
Really?
Yeah. Surgeons who might normally take out gallbladders or repair hernias just thrust into a mass casualty war roll overnight. They're being forced to orchestrate that 8-part symphony almost entirely by themselves, operating far outside their normal scope of practice.
I mean, how do you even begin to triage that? The report talks a lot about this concept, damage control resuscitation, which sounds like a military tactic, but it's actually a medical philosophy, right?
It is. It's the defining philosophy of trauma surgery.
Yeah.
Damage control resuscitation is the conscious decision to prioritize immediate survival over a perfect, definitive repair. You are basically fighting a war against what we call the lethal triad of trauma. That's hypothermia, acidosis, and coagulopathy.
Okay, wait, hypothermia. I mean, I understand that coagulopathy, which is the blood losing its ability to clot, is bad.
Yeah.
And obviously bleeding out is fatal. But why does it matter so much if the trauma patient is cold?
It matters because clotting isn't just a mechanical plug. It's a highly complex chemical cascade.
Oh, I see.
Yeah, the proteins and enzymes in your blood that form clots are heavily temperature dependent. So if a patient's core body temperature drops below 34 degrees Celsius, those enzymes essentially freeze up and just refuse to work.
Oh, wow.
You can pump them full of clotting drugs, but if they are cold, the blood simply will not clot.
That is wild. And what about the acidosis part of that triad?
Well, when you bleed heavily, your tissues stop getting oxygen. To survive, your cells switch to anaerobic metabolism, which produces lactic acid as a byproduct.
Like when your muscles burn during a workout.
Exactly. That acid builds up in the blood. And just like the cold, a highly acidic environment destroys those clotting factors.
So bleeding makes you cold and acidic, which physically destroys your ability to clot, which just makes you bleed more. It's a terrifying, lethal loop. But the report actually notes some massive triumphs in breaking that loop, right? They implemented walking blood donor pools.
Yes, literally having civilians on standby to walk in and donate fresh whole blood on the spot.
Which is amazing.
It is, because fresh whole blood is the holy grail in these situations. It contains warm, active platelets and clotting factors that haven't been degraded by refrigeration. They also used a strict 1-to-1-to-1 ratio of red blood cells, plasma, and platelets for their transfusions.
And the results were huge.
By doing this, they reduced deaths from exsanguination bleeding out by an estimated 18% compared to earlier in the conflict.
That is a phenomenal victory. But, reading further, Dr. Lankarani is unflinchingly honest about where the protocols broke down. There is a drug mentioned called tranexamic acid, or TXA. From what I understand, it's a miracle drug for trauma because it prevents blood clots from breaking down once they form.
Right.
But it has a very strict golden window. You have to administer it within the first 60 minutes of the injury.
And the data shows only 34% of casualties actually received TXA within that golden hour.
Was that a supply chain issue? Like, did they just run out of the drug?
In many cases, no. They had the drug. The failure was purely logistical and environmental.
How so?
Well, victims were trapped under tons of concrete rubble. So the time it took to extricate them, transport them, and then physically find a viable vein to start an IV line, it simply pushed them past that 60-minute mark.
Which means the doctors are starting from behind the moment the patient even rolls through the door. And that leads to a phenomenon the report calls fluid creep. This really struck me. I've always imagined that in an emergency, you just want to pump fluids into someone as fast as possible.
Right, that's the instinct.
But junior medical staff, under immense panic, were giving mass casualties massive boluses of crystalloid fluids, which is basically just IV saline.
What's fascinating here is that the protocols didn't fail because of a lack of medical knowledge. Every doctor knows you shouldn't dump liters of clear saline into a bleeding trauma patient.
Right.
The failure was a product of cognitive overload. When the senior decision makers are spread too thin across dozens of critical patients, the junior staff are left alone. And the sheer panic of watching a patient's blood pressure crash triggers a muscle memory response, which is to push fluids.
It's like trying to fix a leak in a high-pressure pipe with glue, but you start panicking because water is going everywhere, so you start watering down the glue, just trying to fill the space. Eventually, the glue is so diluted it completely loses its chemical ability to seal the crack.
That is an excellent way to conceptualize it. You are increasing the pressure inside a leaking vessel with a fluid that cannot carry oxygen and cannot clot.
Wow.
The environment simply overwhelms the training.
So assuming a patient survives that chaotic initial wave, they get the whole blood, they avoid the fluid creep, they survive the golden hour, the adrenaline in the room drops a fraction. But now the surgeons have to look down at a shattered leg or a catastrophic head injury.
And right at that moment, the city's power grid fails.
Just to make it worse.
Exactly. This is the second monumental hurdle the report outlines. Surviving the bleeding just unlocks the next impossible task, which is saving limbs and brains in an austere environment.
Let's focus on the limbs first, the orthoplastic section. You have these horrific blast injuries where the bone is pulverized, muscle is missing, and the wound is heavily contaminated. The standard of care is something called negative pressure wound therapy.
Essentially, these are specialized vacuum pumps placed over a sealed wound.
Okay.
Pulling a negative pressure on a wound does incredible things. It physically sucks out infectious material and excess fluid, which decreases swelling.
Makes sense.
And by decreasing the swelling, it actually pulls fresh blood flow and nutrients into the tissue bed, which stimulates the cells to grow and close the gap.
But those machines require electricity, and the report details how Maine's power was constantly failing. So the surgical teams adapted, right? They cannibalized battery systems to keep these vacuums running off the grid. It's an incredible piece of MacGyver-level resourcefulness. They kept the wounds perfectly clean.
They did. But a clean wound is only step one. A massive blast injury usually requires a plastic surgeon to perform a free tissue transfer, a flap, where they take muscle and skin from another part of the body and microsurgically attach it to cover the exposed bone.
And this is where they hit a terrifying wall. The report highlights a severe shortage of plastic surgeons. They were almost entirely mobilized elsewhere.
Right.
So you have these beautifully clean wounds, but absolutely no one to do the complex closure. The data shows a median delay of 11 days before patients could get that flap coverage.
11 days with exposed bone is a catastrophic delay.
I can imagine.
Bone does not have a robust blood supply of its own, meaning it cannot easily fight off bacteria. An 11-day window is basically an open invitation for deep bone infections, specifically osteomyelitis. A brilliant initial intervention with the battery-powered vacuums is ultimately undermined because the highly specialized surgeon needed for step 2 just isn't in the building.
Which brings us to the brain injuries. And I have to say, the neurosurgery section of this report feels almost like science fiction.
It really does.
With high-velocity fragments and drone munitions, the trauma to the skull is devastating. The brain starts to swell. And because the brain is trapped inside a rigid bone box, that swelling has nowhere to go but down, crushing the brainstem, which is instantly fatal.
To prevent that, surgeons perform decompressive craniectomies. They physically saw off a large portion of the skull to give the swelling brain a window to expand outwards safely.
But again, there are almost no neurosurgeons on the ground, so they are having general surgeons in forward operating bases do this incredibly delicate procedure using telementoring.
Yes, via satellite.
They set up live satellite video links with expert neurosurgeons in Tehran. So the expert is miles away, watching a screen, verbally guiding a general surgeon's hands through the process of extracting skull fragments from the frontal lobe.
It's intense.
And the report says they saved 26 patients that way.
It is an absolute miracle of modern telecommunications and surgical bravery. The ability to project elite neurosurgical expertise into an austere combat zone via satellite is a profound force multiplier.
Okay, I hear that, and it sounds amazing on paper, but I have to push back here.
Okay.
Is telementoring via satellite actually a scalable solution in a war zone? Or is it just a high-tech Band-Aid? It feels like an incredible parlor trick that distracts from the terrifying reality that the healthcare infrastructure has totally collapsed.
Well, you are touching on the exact paradox the author highlights. It is a Band-Aid. If we connect this to the bigger picture, a perfectly executed remote-guided brain surgery can still fail completely if the downstream infrastructure doesn't exist. And in this case, it didn't. They had absolutely no post-operative neuro-ICUs.
Meaning you do this miraculous surgery via satellite, save the patient's life on the table, and then wheel them into a standard overwhelmed general ward.
Precisely. Traumatic brain injuries require intense, continuous monitoring of intracranial pressure for days or weeks after the surgery. If the pressure creeps up, blood flow to the brain drops, causing what we call secondary brain injury.
So like microscopic strokes.
Yes. Because they didn't have pressure monitors, these secondary injuries from hypoperfusion went completely undetected. The patients slowly deteriorated in the wards.
You win the surgical battle, but lose the physiological war. And the lack of resources led to a really dark phenomenon Dr. Lankarani calls triage fatalism.
Yeah, this was tough to read.
The report details how patients would arrive with bilaterally fixed and dilated pupils.
In emergency medicine, dilated, unresponsive pupils usually indicate catastrophic, irreversible brain damage.
Yeah.
The brainstem is being crushed.
So under mass casualty protocols, these patients were labeled expectant, which is the clinical sanitized term for leaving someone in a corner to die with palliative pain relief.
Right.
But later, when they reviewed the autopsy data, they found that about 15% of those patients might have actually had surgically reversible blood clots causing the pupil dilation.
In a peacetime setting in a modern city, every single one of those patients gets rushed to a CT scanner to confirm exactly what is causing the dilation. If it's a surface blood clot, you open the skull, evacuate the clot, and the patient often wakes up. But in a war zone, the CT scanner is either broken, lacking power, or backed up with 50 other patients.
Wow.
A dilated pupil becomes a definitive death sentence because the system cannot afford to spend 2 hours exploring a skull on the 15% chance of survival when there are 10 other patients who will definitely survive if operated on immediately.
So what does this all mean? We're seeing a repeating pattern. The immediate, desperate, life-saving maneuver is executed, but the follow-through is completely missing because the system is starved.
Exactly.
Saving a life in the first 24 hours is only half the battle. And the source reveals this terrifying concept of a rehabilitation void. For anyone listening who has ever had, months of physical therapy just for a torn ligament or a sprained ankle, imagine having a limb salvaged by a makeshift plastic tube and then being sent home into a war zone with zero follow-up care.
The rehabilitation void is incredibly visible in how they had to manage burn injuries.
Right.
Because of secondary thermal blasts from ignited gas lines and residential fires, burns actually outnumbered shrapnel injuries 3-to-1 in certain corridors. And predictably, the supply chains completely snapped.
They ran out of fluids.
They ran out of intravenous lactated Ringers, which is the specific balanced hydration fluid required to keep severely burned patients alive.
Because when you are severely burned, your skin loses its ability to hold in moisture.
Yeah.
Right. You essentially evaporate to death.
Exactly. Burn shock is a massive loss of fluid volume. When the IV bags ran dry, the medical teams improvised brilliantly. They pivoted to using the World Health Organization's oral rehydration solution.
Just the simple packets of salt and sugar you mix with drinking water.
Yeah.
Because if the veins are collapsing, you just use the patient's own digestive tract to absorb the fluids. The report says it maintained their kidney function perfectly. It was a massive win. But then the improvisation hit its limit. They ran out of sulfitazine.
Silver sulfatazine is the standard topical antimicrobial cream. It is vital for preventing burn wounds from becoming infected. When the stockpile vanished, they were forced to use honey-impregnated gauze.
Which sounds holistic, but in this context, it was a disaster.
Right, because honey does have natural bacteriostatic properties.
Yeah.
It creates an osmotic gradient that draws moisture out of bacteria. For minor burns, it can work.
But for major burns.
For major, deep tissue thermal burns, they are a breeding ground for a specific terrifying bacteria called Pseudomonas.
The report emphasizes Pseudomonas. It thrives in dead tissue, and the honey was completely outmatched by it.
Completely.
Without the modern antimicrobial creams, they saw a massive spike in late-stage septic deaths. People survived the initial fire, survived the fluid loss, only to die weeks later from unmanageable wound infections.
And even for those who survived the infections, there was no dedicated burn rehabilitation, no custom splinting, no occupational therapy to stretch the healing skin.
So what happened?
Patients were discharged and developed severe neck and hand contractures, meaning the scar tissue tightened so aggressively it locked their joints in place permanently.
The long-term physical toll is staggering, and we see that same devastating long-term cost in the vascular surgery data.
Well, the vascular data is a perfect encapsulation of the whole report. Surgeons were facing blown-apart legs. To save the limb from immediate amputation, they deployed temporal vascular shunts.
Okay, what are those?
You insert a small plastic tube directly into the severed ends of an artery to restore blood flow immediately. It buys time while the patient waits for a complex vein graft repair.
And it worked. They restored pulses in 89% of cases. But here is the catch, and it's a brutal one. The strict medical guideline dictates those temporary shunts must be removed and the artery definitively repaired within 24 hours.
Right.
But the wards were so understaffed and the surgical backlog was so immense that patients were left with these shunts in their legs for an average of 38 hours.
Which is more than enough time for bacteria to colonize the plastic tubing.
Oh, no.
Yeah, it led to severe line sepsis and clots. Limbs that had been miraculously salvaged on day 1 ended up having to be amputated on day 4 because a temporary fix had become the source of a lethal infection.
Furthermore, because the surgeons were moving so fast just to save the limb and get the patient off the table, they were routinely tying off severed, paired popliteal veins in the legs without ever going back to reconstruct them.
Right, the popliteal vein is a major vessel responsible for returning blood from the lower leg back up to the heart.
So they fixed the artery to get oxygenated blood down into the leg, but they permanently tied off the main vein that brings the deoxygenated blood back. It's like an engineer repairing a city's inbound supply highway, but permanently destroying the outbound lanes.
That's exactly what it's like.
The traffic, or in this case, the blood, just pools at the destination. It creates massive pressure. The report says this dooms survivors to lifelong chronic venous insufficiency and massive stasis ulcers. Why is the medical system so hyper-focused on the first 24 hours, while seemingly completely blind to the next 24 years of a patient's life?
Because the entire medical apparatus is operating in a state of acute existential survival. Long-term morbidity, what happens 20 years from now, simply doesn't register on the cognitive priority scale when the hospital roof might cave in tomorrow.
Right, that makes sense.
And that constant grinding threat brings us to what might be the most profoundly disturbing finding in Dr. Lankarani's entire report: the hidden casualty of the war, the psychological and ethical toll on the surgeons themselves.
The source details 90 continuous days of aerial threat over the Qom-Isfahan corridor. Bombs falling, sirens wailing, mass casualties arriving relentlessly day after day. And it's not just that the surgical teams are physically tired. The extreme environment is actively rewiring their brains and fundamentally altering their medical ethics.
It really is.
Yeah.
The report defines a phenomenon called utilitarian triage drift. In disaster medicine, the ethical gold standard is utilitarianism. You prioritize the most salvageable patients to do the greatest good for the greatest number.
Okay.
But over 90 days of exhaustion, fear, and sleep deprivation, the data shows that noble principle slowly began to mutate.
It drifted. It shifted from save the most salvageable to save the quickest to close.
Exactly. A highly complex surgical case that might take 3 hours, even if that patient was young and had a great chance of survival, was increasingly pushed aside or left expectant.
In favor of patients who could be patched up and cleared from the operating table in 30 minutes.
Yes. They were quietly abandoning highly survivable, complex cases just to keep the conveyor belt moving.
You know, I read that, and my initial reaction was horror, but then I stepped back. Can we really blame these doctors for this drift? When they are running on zero sleep, surrounded by trauma, with no supplies and absolutely no backup, aren't they just trying to survive this shift?
This raises an important question. How do we categorize human endurance in professional settings? We tend to view a surgeon's clinical judgment and ethical compass as fixed, static traits.
Yeah, like they're superheroes.
But this data definitively proves that cognitive reserve is a physical, depletable resource. It runs out, exactly like blood or oxygen or antibiotics. When a surgeon is cognitively depleted, their technical complication rates skyrocket.
The numbers back that up in a terrifying way. 40% of the surveyed general surgeons met the clinical criteria for moderate to severe moral injury. And this wasn't just them feeling burnt out or depressed. The report notes a measurable statistical decline in their physical surgical performance. For example, they became significantly worse at fixing anastomotic leaks.
An anastomotic leak is when a surgeon stitches 2 ends of the bowel back together, but the connection leaks intestinal fluid into the abdomen. It is a highly complex, technically demanding problem to fix. It requires immense mental focus and fine motor control.
And as their moral injury increased, their ability to successfully salvage those leaks plummeted. Their minds and their hands were simultaneously failing under the weight of the choices they were forced to make, and that moral injury was compounded by what the report calls the consent void.
Right. In the utter chaos of a mass casualty influx, terrified civilian patients were being rushed into operating theaters without anyone taking the time to get informed consent or explain the surgical plan.
I can't even imagine.
A patient would be put under anesthesia, wake up missing a leg, and a junior intern would have to explain it to them 3 days later.
That completely corrodes the fundamental trust between the medical corps and the community they are desperately trying to save. But amidst all this darkness, the report does point to administrative solutions that actually worked. To combat the moral injury, they instituted mandatory peer support balance groups.
Bailout groups are structured, psychologically safe debriefing sessions. After a brutal shift, the surgeons sit down and actively process the emotional weight of the cases they just handled. It prevents the trauma from calcifying into permanent psychological damage.
And they also created transparent resource allocation boards. They put a whiteboard in the center of the surgical hub, physically writing out exactly how much blood, how many surgical kits, and how much operating theater time was left. And it completely stopped the panic and the infighting over resources.
It is a brilliant psychological buffer. By externalizing the resource scarcity onto a public whiteboard, the administration removed the crushing ethical burden from the individual surgeon. You don't have to agonize internally over who gets the last unit of blood if the board clearly dictates the mathematical reality for everyone to see.
It is incredible how a simple dry erase marker can literally save a surgeon's sanity. So to briefly recap the journey we've been on today, Dr. Lankarani's report shows us that while technical surgical skills can scale up rapidly in a crisis, we saw general surgeons successfully drilling burr holes into skulls via satellite and placing complex vascular shunts.
It's amazing what they accomplished.
It is, but it's the system vulnerabilities that dictate true survival. The fragile supply chains, the devastating rehabilitation void that ruins lives decades later, and the finite, depletable mental endurance of the teams on the ground.
And that is why these field-sourced, unfiltered appraisals are so vital to the medical community. They aren't just academic abstractions living in a journal.
No.
They are profound, blood-soaked lessons in how fragile human-made systems are when they are pushed to the absolute brink. They force us to rethink how we train, not just for the perfect peacetime operation, but for the extreme, resource-starved environments of the future.
And they force us to look in the mirror. Here's where it gets really interesting. The report explicitly states that high-fidelity simulation and psychological conditioning are needed to inoculate these surgeons against cognitive overload. But what about the rest of us?
That's the great point.
In our own high-stress, resource-depleted moments, whether that's navigating a massive crisis at work, dealing with an emotional emergency in our families, or facing pressures in our communities, how vulnerable is our own daily decision-making to that exact same utilitarian drift? How often do you, the listener, under immense stress, quietly shift from doing what is actually right to doing what is simply quickest to close? Think about that the next time you feel your own internal system starting to overwhelm you. Thank you so much for taking this deep dive with us.